Hello, my name is Valérie Ducret and I'm a research scientist at Okin, an AI biotech company focusing on finding the right treatment for every patient. In this video, I will present our collaborative work with Dr. Janagin Chakraborty and Nazar from the Memorial Sloan Kettering Cancer Center in New York. Let's start with a general introduction. Intrahepatic Cholangiocarcinoma is a type of cancer that originates in the bile ducts within the liver. It is a relatively rare form of cancer, accounting for approximately 10 to 15% of all primary liver malignancies. Unlike other types of bile duct cancer that occur outside the liver, intrahepatic cholangiocarcinoma specifically affects the bile ducts within the liver itself. Although it is considered a rare disease, its incidence has been steadily increasing over the years. In fact, studies have shown that intrahepatic cholangiocarcinoma is now the second most common primary liver cancer, following hepatocellular carcinoma. Survival rates for patients with intrahepatic cholangiocarcinoma are generally lower compared to other types of bile duct cancer. The prognosis for intrahepatic cholangiocarcinoma is often poor due to factors such as late diagnosis, limited treatment options, and a high likelihood of recurrence following surgical resection. These challenges highlight the need for improved predictive models and biomarkers that can help inform prognosis and guide personalized treatment decisions. In this context, deep learning methods provide a new opportunity for that by extracting distinguishing characteristics, interrogating multiple data sources, which appears in previous studies to be sometimes superior to unimodal modeling. Thus, in this work, we aim to construct a predictive model of patient outcome and identify predictive biomarkers based on a combination of clinical, genomic, and histological data. In particular, we designed a multimodal model to predict overall survival and progression-free survival. Our data is composed of 83 patients with intrahepatic cholangiocarcinoma that underwent surgery and for which we have clinical information. We also have information about hematoxylin eosin histology slides, and for the majority, we also have information about genomic alterations. As a pre-processing step, we imputed missing clinical information with the median value for each variable. The pre-processing for the images is a bit more complicated because of the high dimensionality of this modality. Each histology slide was decomposed into patches, also called tiling, and each patch was fed into a ResNet feature extractor to extract a feature representation of the patch. Then the features across patches were aggregated with maximum pooling to yield a 2048 dimensional vector representation for each slide. Among these 83 patients, 76 patients had their tumors profiled for somatic genomic alterations using MSK Impact, a deep targeted sequencing assay. Due to the sparsity of the data, we aggregated genetic alteration, copy number alteration, single nucleotide variants, and structural variations to produce a binary matrix of altered genes. Top altered genes were used as input in the prognostic model. Cox proportional hazard models specific to each modality, clinical data, histological slides, and altered genes were then designed, and their predictions were averaged to produce a final log risk score for the multimodal model. Unimodal and multimodal models were validated using a 5-fold, 5-repeat cross-validation with patient-level splits. As a measure of model performance, we use the concordance index or C-index. It measures the concordance between predicted risk or survival probabilities and the actual outcome. Regarding the results, we globally see an improved performance as we had more modalities as input. For instance, a model using only clinical and routine histological data achieved a concordance index of 0.74 for overall survival and 0.73 for progression-free survival after cross-validation. Adding information about genetic alterations improved performance for OS and similar performance for PFS. Both models outperform a staging-based patient stratification that has a C-index of 0.66 for OS and 0.69 59 for PFS. Kaplan-Meier curves provide a visual representation of survival probabilities over time for different patient groups. Here, low versus high-risk patients. By comparing with the model based on clinical staging, we can assess the effectiveness of our machine learning-based stratification in predicting patient prognosis. To interpret the Kaplan-Meier curves, one has to focus on the separation between the curves. A larger separation indicates a more significant difference in survival between the patient groups being compared. As we can see here, the machine learning-based model shows a greater separation compared to the clinical staging-based model, in particular between the time window of 40 to 60 months, which suggests that our approach is better at stratifying patients based on their prognosis, potentially leading to more accurate treatment recommendations and improved risk assessment. To conclude, our study demonstrates that machine learning models can enhance survival prediction using multimodal data after resection of intrahepatic cholangiocarcinoma. These models have the potential to improve risk stratification and treatment recommendations, offering patients a more personalized approach to their care. Moving forward, further investigations should focus on validating and refining the machine learning models in larger and diverse patient populations, as well as exploring the integration of additional data sources to enhance the predictive accuracy and guide targeted therapeutic intervention. Thank you all for your attention.